shall we start with the next session? It's on ocular pathology and oncology, beyond the surface. Is Dr. Chandana Chakravarti present here? Yours is first talk, ma'am, in the list. Eating the flesh, clinical virginity of periocular necrotizing fasciitis.
Good afternoon. At the outset, I want to thanks to AIOS for giving me the opportunity to speak in this podium. I'm going to talk on eating the flesh, the clinical vignette of periocular necrotizing fasciitis, no conflict of interest. I'll quickly go through a case scenario and then discussion part. A 50-year female came with pain, swelling, pus discharge from the periorbital area 1 week. There was history of trauma with a tubal handle 1 week back, treated outside the oral and topical antibiotics, oral anti-inflammatory drugs, but then there was not much improvement. On examination, this was the picture. There was erythema in the periorbital area. Along with that, some pus, discharging pus, anterior posterior segment was within normal limit. The necrotic texture you can see. Anterior segment was within normal limit. This was the axial CT scan showing the hyperdense area lesion in the lead area. That is the necrotic area. This was the blood investigations picture. The patient, though the patient had no history of diabetes, but the patient blood picture was sugar was very high. WBC count was also high, ESR high, and CRP was very high. So what we did is that on the very first day, we did the surgical debridement of the area and gelone dressing. And this was continued for the next 1 week. Every day we used to do this, the cleaning and the until there was appearance of the healthy granulation tissue, as seen in this picture. The healthy granulation tissue will appear, then we stopped the dressing. And after the granulation tissue came, then we asked the patient for that we need a grafting, but unfortunately the patient refuses any further surgery. After 1 month, the patient came back, and this was the picture at 1 month. Somehow the patient, there's not much deformity except slight lower lid ectropion in the left eye. The patient refuses any grafting. Another case scenario, 4-year female child, swelling, pain the left eye, fever, 1 week, pain, no history of trauma apparently. Child was very irritable and there was fever. So we started the patient on ceftriaxone initially, but it was not much responding, very minimum response. So we quickly the patient turned to this picture. After 1 week, this was the picture. This was the CT picture. As you see, the periorbital area, there is swollen tissue with emphysema. The blood picture is similar like the last patient, high WBC count. In this case, when the patient was not responding with the ceftriaxone, then we started on injection piperacillin and tazobactam. This was given 750 mg for 10 days. Debridement of the necrosed tissue every day. And finally, this was the picture which came. And then we went for the grafting from the retroauricular area. We took the graft and put it. This was the before and after treatment of the patient. Necrotizing fasciitis is a severe infection. Periorbital necrotizing fasciitis is actually very rarely seen. It involves the superficial and the deep fascia along with the overlying skin. The periorbital NF is uncommon because of the excellent blood supply of the periocular area. Predisposing factors, you must be knowing that these are basically penetrating trauma, pre-existing abrasion, lesion, surgical site, blunt trauma, but sometimes in 1/3 of the cases no cause has been found out. Immunosuppression is one of the risk factor. The organisms involved, depending upon the, we divide, there are two types of the NF are seen in the periorbital area. One is NF1, one is NF2. In case of NF1, it is a polymicrobial infection, that is the gram-positive and gram-negative, both the organisms are involved here. And in NF2, the infection is either streptococcus or staphylococcus, but in general, group B, mainly the beta hemolytic streptococci. In 50% of the cases, this is the culprit, the beta hemolytic streptococcus. Others are rare organisms are Pseudomonas, Propionibacterium, Acne, Serratia, Citrobacter fungus. The basic pathophysiology is that is angiothrombotic microbial infection, liquefactive necrosis of the subcutaneous tissue, initially the superficial fascia, and then the deep fascia is also involved. The ischemic necrosis of the skin develops along with the gangrene of the subcutaneous tissue. The clinical features of NF one should know, because the clinical feature is the main diagnostic factor, that there is erythema. And once the necrosis develops, then it becomes easier to diagnose the thing. Sometimes in the initial phase, you can get blisters over the erythematous area. There is pale, and the pain is actually more than the signs. The pain is exorbitant pain. So diagnosis of NF depends, as I told, on the clinical features. The imaging, the periorbital soft tissue edema, and sometimes the emphysema, and the lab investigation. Lab investigations actually, there is the LARNF, laboratory risk indicator, so which includes the 6 factors like leukocytosis, then C-reactive protein, creatinine, hemoglobin level, and the blood sugar level. All these 6 factors, so when this total scoring goes beyond the 6 or more, then you can say that this is going to be in case of necrotizing fasciitis. This is 12 cases I have seen, we have treated so far. Among these, 7 were female and 5 male. 50% of the cases are from diabetes and alcoholic history. Differential diagnosis is also important, orbital cellulitis and all. Management, as I told, the early recognition is very important to decrease the mortality and morbidity. Combination of beta-lactam antibiotics such as penicillin, cephalosporin, clindamycin. Clindamycin it has a synergistic effect. It deters the production of the streptococcal toxins and enzymes. In polymicrobial type, periorbital necrotizing fasciitis may require the addition of aminoglycoside and metronidazole. In most of our cases, we included this metronidazole also. Intravenous gamma globulin, some role. Prognosis is mortality is less than the NF in other areas like in the limbs and in the perineum. Periorbital mortality is NF is less mortality, but morbidity is there, like optic neuropathy, retinal vein occlusion, exposure keratopathy, cavernous sinus thrombosis. Cosmetic disfigurement one has to manage, may requires surgery later. So this is important to diagnose, and it needs a multidisciplinary approach. Sometimes the plastic surgeon may be required to manage this disfigurement. These are my references, my team. Thank you.
Ma'am, for my knowledge sake, before the skin becomes necrosed, is there any way to suspect it? That is a definite.
Of course, there is erythema, the redness, along with that pallor, redness along with pallor in some areas, and there is blisters, some discharging blisters, because 2 cases so far we have found this type of infection, and it is not improving to any conventional antibiotic like ceftriaxone and all. Then you have to, sometimes most of the cases, at least 1/3 of the cases, as I told, no history is there, like no history of any injury, but there may be a very trivial lesion that can also give rise to this type of infection.
Thank you.
Thank you, ma'am, for the excellent presentation. Any questions from the audiences? Thank you.
Thank you.
So we move on to the next talk by my mentor, Dr. Santosh Anawasa, on logical management of aponeurotic ptosis.
Good afternoon. The next 7 minutes or so, I'll be speaking about aponeurotic ptosis. Aponeurotic ptosis, also called involutional ptosis, has disinsertion of the levator, dehiscence of the levator, or degeneration. Just remember the 3 Ds as the possible mechanisms. Along with disinsertion or dehiscence, degeneration could be a component, or degeneration sometimes could be standalone without any dehiscence or disinsertion. Involution is typically age-related, but exactly similar ptosis can happen in patients who have had inflammation such as blepharocharesis, trauma, use of rigid gas permeable contact lenses, patients with chronic VKC, eye rubbing, allergic eye disease, mechanical causes such as recurrent chalazion. Anything can cause involution like aponeurotic ptosis. Typical features are that it is bilateral. As you see here, it is bilateral symmetrical. It could be bilateral asymmetrical. Left eye does have ptosis. When you lift the right eye does have ptosis. When you lift the left upper lid to its non-ptotic position, the right eye droops, that is herrings. Then it could be even unilateral. As you see here, this patient had a history of cataract surgery with a brittle suture of the superior rectus, following which he developed acute onset ptosis. Typical features are that there will be accompanying laxity of the eyelid skin, as you see here, high or faint eyelid crease, deep supratarsal sulcus. They invariably tend to have good levator action, 10, 12, 13, 14 millimeters. They have thin eyelid, and in a fair individual in a well-lit room, you can actually see the uveal reflex shining through the lid when the patient gently closes the lid. They also have canthal dehiscence. The lateral canthal angle, which is supposed to be sharp, gets blunted, and the ratio between the medial limbus to medial canthus to lateral limbus to lateral canthus, which is supposed to be 2:3 in Asian Indians, gets altered to perhaps 1:1. So lateral canthal dehiscence can be an accompanying feature which some patients want corrected. Like this patient has a narrowed lateral canthus to lateral limbus distance, and he also has difficulty in down gaze or climbing downstairs. That's because their palpebral fissure nearly closes when they look down. That's one of the complaints. Many of these patients come with difficulty in reading. When you see these patients, you have to look at what's the severity of the ptosis. Are there any complicating factors such as dry eye, or even for that matter, a giant fornix syndrome or a floppy eyelid that cannot be associated, that can complicate the surgery? Is surgery going to be safe for the patient, and what is the expected outcome? Critical information that you derive are just the same, but in addition you do the phenylephrine test to see if this patient would be a candidate for mullerectomy, and if so, then you could go ahead with it. Cosmetic indications overwhelm functional indications for surgery currently. Many patients who have functional indications are elderly and they don't prefer to undergo surgery. They somehow manage, but younger individuals are definitely keen on cosmesis. The surgeries that you perform, of course, mullerectomy and then levator reattachment or plication. Very few patients undergo fascicular severe procedure, that is a surgeon's choice. In levator reattachment, is classically for patients who have levator disinsertion, and we tend to do it in patients who have good levator action. We generally reinsert the levator to the middle or upper 1/3 of the tarsus, and sometimes we hang back if the levator action is even better. What I have found is that when the levator gets disinserted, it rolls back and gets attached to the orbital septum. This we find in a majority of patients like so. Now this is the edge of the levator that had rolled back and got attached to the septum. But this is actually the edge of the levator which is disinserted. You can see the aponeurotic component, and you can see the muscular component, and you can see fat infiltration in the muscular component. This is the zone of the Whitnell's ligament. So clearly this edge was not towards the tarsus. This edge was towards the septum. That happens because this edge got disinserted from the tarsus and it flipped back and got attached to the septum. This is a curious finding. Initially when I saw it, I thought, this could be just a freak case, but over a period of time, since I have been operating under an operating microscope with very high magnification, I've been able to recognize this in a majority of patients. And if you don't recognize this, you consider the knee where it bends as the real disinsertion, and you would attach this area to the tarsus, resulting in overcorrection. So if you identify this folded edge of levator, then you will be able to give a better result, I suppose. Now I'll show you a video clip which also shows the same. I'll skip these initial parts of the video. Yes, now dissection of the orbicularis, exposing the septum, then we are dissecting the tarsus. See, that's the edge of the rolled edge of the levator, which is attached to the septum. I am disinserting it from the septum with very low RF. Sometimes it's difficult to dissect this layer with scissors. You can see the muscular components peeping through. That's the muscular component. That's the aponeurosis. That's the Whitnell's ligament. It's very clear, the distinction between the aponeurosis and the muscular component. And then we simply reattach it. That's all the surgery. Where to reattach depends on the levator action and the length of the aponeurotic component that is visible. Sometimes in patients who have inflammation as the etiology, the aponeurotic component becomes extremely short. It becomes hardly 5 or 6 millimeter. That means that there is already natural resection because the aponeurosis has already undergone shrinkage. In such patients, if you reattach the aponeurosis to the middle of the tarsus and tie your sutures tight, then this patient is likely to have overcorrection because he has a natural resection effect already. So in such patients, we hang back the levator. It means the sutures are still taken through the upper 1/3 or 2/3 of middle of the tarsus, but the sutures are tied loose so that there is a hang back effect. With that, you are able to get much better results. These are some of the patients who have undergone levator reinsertion, and they do quite well. And more importantly, their functional component of not being able to see in down gaze also gets resolved because their cornea gets exposed in down gaze. Levator plication is specifically for patients who have levator dehiscence. The rule of thumb is 6 millimeter plication for every millimeter of ptosis. That is surgeon dependent. You can start with this particular thumb rule and keep on altering till you get or optimize your results. The initial steps of the surgery are the same. There is hardly any difference in the initial few steps. We have to identify that there is indeed dehiscence and not disinsertion before you plicate. You mark exactly the amount of plication that you want to have. I use these 2 dots for each arm of the suture to come out. Lamellar tarsal bite with 6-oproline suture. Make sure that it has not gone full thickness to the tarsus. Then take a bite at the upper edge of the tarsus so that the plicated tissue lies at the upper edge and not comes over the surface of the tarsus. Then it may blunt the lid crease formation. Then go through the levator and come out at the intended site, which you see. That's the bite at the upper edge of the tarsus. Then you take one more bite and then come out at the intended point where you want to plicate. All 3 sutures are 6-O-proline. You can use a double arm suture as well if you're comfortable with it, or single arm suture, surgeon's choice. Similarly, medially and laterally. So all the 3 sutures are passed through the intended points and simply have to tie these sutures, giving the plication effect. This is one patient where the left eye has undergone plication, doing fairly well. Here is the left eye again having undergone plication. Right eye undergone plication. The lid crease also forms nicely with this technique. So in involutional ptosis, the most important aspect is to identify what has caused this, whether it is disinsertion, dehiscence, degeneration, or a combination of those. Identify the etiology first and try to address it. Mullerectomy is a very good choice, but I'm not talking about it because the time is 7 minutes. So mullerectomy is an extremely good procedure. I have only addressed levator reinsertion and plication. And of course, you can do levator resection in patients who have poor levator function, say 6, 7, 8 millimeter levator function, which is considered fair, but not good enough for levator reattachment. In such patients, you can do advancement or small resection as well. Perfection is an unreasonable goal in ptosis surgery. This you have to explain till the patient understands. And if at all you have a surprise undercorrection or overcorrection, don't wait for the tincture of time, but go ahead and adjust it. I do all my adjustments under topical anesthesia. Patients generally don't have pain once, you simply can use topical anesthesia and adjust even in patients who are young. They cooperate fairly well. So we adjust early. In about 15 to 20% of patients we need to do adjustment, and that we generally do in the first postoperative week itself. Thank you so much. Questions?
Thank you, sir.
Any questions?
Any questions from the audiences?
May I call upon our? Okay.
Yeah.
Yeah, you can use adjustable sutures, but in that situation, every patient has to be has to have a finalization of sutures. I don't use externalized adjustable sutures, but I tell my patients that you may be required to have an adjustment, especially when the length of the aponeurosis is so variable and the levator action is so variable. You may get surprise undercorrection or overcorrection. That may happen in 1 in 10 patients, but if the patients are informed that they may need adjustment, they are mentally prepared. The only point that the patient winces is when you take off the skin sutures. Beyond that, just use proparacaine drops, 3 or 4 drops, and we can actually pass the sutures again under topical anesthesia, and again the patient absolutely has no pain at all. Now the advantage of this is that you can know the exact position of the eyelid, whereas when you do your first surgery, you would have done it under frontal block. Despite using half a cc or 3/4 of cc of frontal block, there would be some mechanical effect of primary surgery, tissue edema for that matter, intraoperative, or little bleed that takes place. By 1 week, everything would have resolved. That's the best time to adjust. Yeah. Correlation I have found is shorter the length of the aponeurosis, and better is the levator action, higher is the chance of overcorrection. And for some reason, patients who use a prosthetic eye where there is aponeurotic ptosis have a very high chance of overcorrection. I haven't found out the reason why.
So, how can we manage overcorrection in postoperative period, early and late?
Well, I mean, people advise stretching of the lid, massage, but I don't think that really works. Right? So, traction on the lid, all these are indirect attempts to loosen the sutures. If you have an overcorrection, it is best to open up and pass the suture at an appropriate height or with appropriate tightness in the immediate postoperative period, say within a week. That will give you more stable results than trying to give traction or massage or do whatever else.
To correct it, the surprises by 2 weeks, is it okay?
2 weeks would be the time when fibrosis would have already started.
As early as within a
Yeah,
week?
within a week, I think tissues are very fresh, and that I found that 5th or 6th day is the best time.
Thank you, sir.
Any other question? Okay. May I invite our next speaker, Dr. Aruna? Her topic is on lid lumps and bumps and overview.
Good afternoon all. At the outset, I would like to thank the organizers of the AIOS for the opportunity. I have no conflicts of interest. And my topic is lid lumps and bumps and overview. This is of interest because we have these lid lesions which can arise from any layer of the skin and can be malignant, pre-malignant, benign, painful, painless, and the list is endless. So when we come to the benign ones, the so-called good lesions, starting from just the epidermoids or the sebaceous cysts as was previously called, and then the melia, which are the white keratin bumps under the skin, then the molluscum, which is the pearly nodules, the xanthelasma, which is the yellow subcutaneous plaque, and the seborrheic keratosis and the papillomatous lesions. The seborrheic keratosis, which looks like a well-circumscribed stuck-on lesion. What we need to remember here is if you have a sudden onset of multiple crops, then we need to rule out an internal malignancy, a GIT malignancy. And then this is the case of the cutaneous horn, so-called because it resembles an animal horn. The horn itself is not of much interest. It is because it's just made up of dead keratin. But then the underlying condition may be pre-malignant or malignant. So it is always mandatory to ensure a histopathological diagnosis and go on accordingly. Of the common dermal lesions, yeah, we have the nevi, which usually these lesions are congenital or seen in early childhood. And here was a patient who presented with a painless lesion since childhood, but then he came to us in the third decade, and on excision turned out to be a hemangioma. Of the adnexal lesions, we all know the chalazion and the hordeola are so common. Apart from that, we have the cystic, the hydrocystoma, which are solitary nodules, which are smooth and found along, arises from the cysts of Moll. And if they contain clear fluid, then they transilluminate, otherwise they don't. And then the syringoma, which are multiple, waxy, elevated nodules. So most of these cases can be treated by a simple excision or shave excision, or maybe a laser or a carbon dioxide as well. And here are some other lesions of the typical S-shaped lid of the neurofibromatosis. And as ma'am already spoke, necrotizing fasciitis, the dermoids, then cellulitis, and these were two interesting patients who presented with malformations. This was a 30-year-old lady who had come to us for recurrent swellings of the upper eyelid, and these which increased on valsalvas. So here it turned out to be a lymphovenous malformation, and so we had advised her for sclerotherapy. And this was another patient who was referred to us from an outside center as an AV malformation who had already undergone partial embolization. So of coming to the next one, which are the pre-malignant lesions, which are definitely not so good lesions, we need to keep these four in mind. The actinic keratosis, which is just having a sandpaper-like texture. Then the keratoacanthoma, which is a kind of a nodule on the lid with a central crater filled with a keratin plug. And then the bovins, which is an erythematous elevated plaque, and lentigo maligna, which deals with the hyperpigmentation. So here it is important because we need to excise with an adequate surgical margin and always follow up on the patients. Finally, the most malignant ones are the very bad lesions. So we know that skin cancers are the most common malignancies, of which eyelid malignancies make about 10%. The basal cell carcinoma, though very, very common, in our part of the world, in the pigmented population, it is the sebaceous gland carcinoma, which takes the upper hand. And the risk factors to be kept in mind, so fair-skinned individuals, immunocompromised, or with previous history of radiation or burns, or even, and then beware of the signs of malignancy. So these are the red flags. When you have the normal lid architecture which is altered, think of malignancy. Then if there's a loss of lashes or tethering to deeper structures, and then the ABCDE, where there's a change in the color, the border, or the size of the swelling, and then the fine telangiectasia, please keep in mind, we are probably dealing with malignancy. So the basal cell carcinoma, we all know that we have the nodular form, the ulcerative form. This was a lady who was referred again to us with query malignancy, query granulomatous lesion, and it finally turned out to be a basal cell carcinoma. These are locally invasive, so we need to ensure that we treat them right away. This squamous cell carcinoma is less common but more aggressive, and the thing to be kept in mind is that here metastasis happens through the lymphatics, through the blood, and through direct neural spread. So definitely it is mandatory to do a regional lymph node examination and a thorough systemic examination. The next is the sebaceous gland carcinoma, which is also called the great masquerader, because of it can mimic chalazion, it can mimic persistent blepharitis. But then the points to keep in mind are the yellow appearance because of the lipoid material, and the loss of the lashes and destruction of meibomian gland orifices. This is very important because it is potentially lethal because of the pagetoid spread and the multicentric origin. The less commonly seen cancers, the malignant melanoma, to be suspected in any individual who is beyond 20 with a fresh new pigmented lesion. Then the Merkel cell carcinoma, which is pretty rare. The Kaposi's, which can be seen both on the eyelid and in the conjunctiva. And finally, to keep in mind, metastasis to the eyelid, which can occur from anywhere else in the body, commonly the lung cancers and the renal cell carcinoma. So surgical management for all these malignant lesions definitely will need surgery unless they are in a very early stage where we can go for alternate forms as well. So it is mandatory that we go for a wide excision. That means leaving at least with a 2 to 3 millimeter margin of normal tissue, preferably with a frozen section control, if not for Mohs micrographic surgery, where tissue preservation is better. And the biopsy can be either the excisional or the punch or the incisional biopsy as well to confirm the diagnosis. And having done with resection, we can think of lid reconstruction, where the principles are, if it's less than 33% involvement, where we go for a primary direct layered suturing, or if it extends up to a 50%, then we go for, as in this case of the basal cell carcinoma, where we went in for a suturing with a canthotomy cantholysis and a Tenzel's flap, and we are having the follow-up as well. And here in the case of the sebaceous gland, where there's more than a 50% involvement, either we can go for lid sharing procedures. Here we went for a cheek rotation flap, the mustard procedure. So my take-home message is a meticulous history taking and clinical examination will go a long way in identifying these lesions early, have an index of suspicion, look out for the red flags of malignancy, look out for the regional lymph nodes, and do a thorough systemic examination, confirm the diagnosis, then ensure a proper complete resection with margin clearance and a follow-up, and if adjuvant therapy if necessary. So I would also like to acknowledge my mentor, Professor Samrapuri, who's the HOD of the Department of Ophthalmology of Stanley. Thank you.
Excellent presentation, Doctor.
Thank you, sir.
Any questions from the audiences?
Ma'am, regarding the surgical management protocol, you said the wide margin excision 2 to 3 millimeter beyond. Is it so, or some says 4 millimeter?
Yeah, it depends on the clinical presentation, what we are suspecting. Suppose if it's a sebaceous gland, we know we are going to have skip areas, so we need to be extra careful, go in for a wider margin there, whereas in the others, maybe a 2 or 3 mm would suffice. Thank you.
Any question from the audience, please?
Thank you.
May I call upon our next speaker, Dr. Nitish Arora. His topic is on Saga of a White Pearl.
Good morning, everyone. I'll be talking about Saga of a White Pearl. So we'll be discussing a case of a 7-year-old girl who presented in my OPD with the nodular swelling in left eye, upper eyelid since 4 months. So there was no other history of childhood trauma or any surgery, no significant past history. On local examination, she had left eye, upper eyelid progressively increasing swelling, which was measuring around 1 by 1 centimeter since 4 months. The swelling was firm in consistency and was painless and immobile. There was no other signs of inflammation. There was no edema, erythema, extraocular movements were full in all directions, and other eye was unremarkable. We asked for a previous picture from the patient, and she presented a picture with which was 3 months before the presentation. There was left eye upper eyelid swelling, and there was no eyelid edema or erythema. There was no proptosis also. So a clinical diagnosis of left eye upper eyelid dermoid cyst was made. We asked the patient to get a CT orbit done, but patient already had got the scan done, and she was there with the report, and she didn't get the films with her. So impression of left eye internal angular dermoid was there, and rule out orbital component was written out there on the report. So we planned for a left eye excision biopsy under general anesthesia, and patient will bring the CT scan before the surgery is scheduled. On CT scan, we could see a well-defined hypodense, thick-walled ovoid cystic lesion measuring around 7 by 9 by 10, seen in the left eye upper lid anterior to the globe. There were no calcifications, perilesional infiltration, intraorbital or intracranial extensions were absent, and bilateral optic nerve and globe appeared to be normal. So blood investigations were done, and differential diagnosis of epidermoid cyst, dermoid cyst, cysticercosis or hydrated cyst was made. But on the day of surgery, patient presented with the inflammation on pain on the nodular swelling area, and there was inflammation on that area. So impression of inflamed dermoid cyst with thinned out skin overlying the lesion was made. So patient was asked to wait for the inflammation to subside and follow up after 1 week. After 1 week, when the inflammation was subsided, but then there was thinning of the skin overlying the lesion, and there was no tenderness, so we planned to continue the treatment for 1 more week. After 2 weeks, when patient came to us, she said that there was bleeding from the lesion and showed the discharge which they have collected on a piece of paper, which appeared lot to be like a cyst. This was the discharge which she had collected. We sent it for the biopsy, and we could see a cystic cavity containing a larval form which had hooklets, and there were autolytic changes. Also, there was no malignant cells or any changes like that seen. Impression was made of a cysticercus cyst. So the diagnosis, we went back to the previous pictures. This is the picture when patient previous to the presentation 3 months back. There was a swelling which was seen in the left eye upper lid. Then this is the picture at the time of presentation. Eventually, when patient had inflammation on the day of surgery, and the day when there was extrusion of the cyst. So we reviewed the CT scan, and in this CT scan, in one of the slides, we had missed this hyperdense opacity, and also we had missed eosinophilia in the patient. So a clinical diagnosis of cysticercus left eye upper lid with spontaneous extrusion was made. So coming to the treatment of this, so complete evaluation for any other cystic lesion was made, and patient was treated with oral albendazole 15 milligram per kg body weight. Maximum dose of 800 milligram OD was given for 6 weeks, and oral steroids alongside prednisolone 1 milligram per kg was started. So this is the picture after 3 months. So this was the first picture is with on the day of presentation, and the second picture is after 3 months after presentation. So cysticercosis, coming to the topic, it is larval form of Taenia solium, which is and human being the intermediate host. Contaminated food and water are the source. Approximately 50 million people worldwide are infected, and around 50,000 come to death annually. Sites of cysticercosis, CNS being the most common and subcutaneous being the least common. Ocular and adnexal involvement is around 1.8 to 4.5 in Indian population. In India, 78% of cases are seen in the states of Andhra Pradesh and Pondicherry. So incidence of ocular cysticercosis, 35% occurs in subretinal space and 1% in orbit. A life cycle, as we discussed, human being the intermediate host and oral route being the commonest, pig is the primary host. So the stages of cysticercosis are live and vascular stage, where there is a living cyst with well-defined scolex, minimal or no inflammation. Colloidal or vesicular is the mysterious stage where the inflammation starts. The cyst becomes leaky and releasing toxins. There are varying degree of inflammation which can be noted. In nodular granular, the calcification starts and the edema or there is decreased enhancement. Initiation of calcification is there in this stage. And then calcified stage, where we can see rounded whitish calcified nodules. In orbital cysticercosis. Extraocular muscle form is the commonest, where medial rectus is commonly involved, and our case is an isolated eyelid cysticercosis, which is around 0.6% of incidence. Subconjunctival space followed by eyelid, optic nerve, and retroorbital space, lacrimal cysticercosis. These are the order. So presentation could be periocular swelling, proptosis, ptosis, pain, diplopia, restriction of ocular mobility, strabismus, lid edema, orbital cellulitis like picture, and subconjunctival presentation could be there, which is secondary stage, might be the cyst has extruded from the primary extraocular muscle site. So diagnosis can be confirmed by serological test, but which may show false positive reports. Imaging are very definitive, where we can see a hyperechoic scolex on a B scan, and A scan also shows high amplitude spikes, whereas a CT scan or MRI are definitive, where we can see a hypodense mass with the central hyperdensity, which is suggestive of a scolex. Other tests are, in our case, there was eosinophilia, which we missed previously, and stool examination can also be done. So management of orbital cysticercosis, in case it is subconjunctival cyst, excision biopsy, and then evaluation of any other neurocysticercosis should be done, and neurological examination followed after that. In case there is proptosis, restricted motility, inflammation, or ptosis, then CT scan should be done for neurocysticercosis or intramuscular lesions. And in intramuscular lesions, we have to see for the scolex. If there is scolex, then we have to start the empirical therapy of oral albendazole and oral steroids. In case there is no scolex, then ELISA should be done and pursued eventually for if it is positive or not, and diffuse myositis should be seen. So this is the empirical therapy which should be started, like oral albendazole, maximum dose of 800 milligram OD, and oral steroids alongside. Medical therapy is recommended treatment for extraocular muscle and retroorbital form of cysticercosis, surgical removal only for subconjunctival or intraocular forms, and treatment of optic nerve and lacrimal gland cysticercosis is still controversial because of limited number of cases. So take home message in my case would be, a location of cysticercosis varies. Non-tender subcutaneous lesion in the patient of low socioeconomic status with typical imaging finding can prevent dreaded CNS complications, and treated with medical therapy gives complete resolution if instituted timely. Thank you.
Dr. Nitish, if you had suppose seen that CT scan carefully and in first go only you could have made that a scolex, would you have gone for surgical excision, or since it's an accessible site, or the medical therapy only?
Yeah, probably we could have gone surgically also, because it is very accessible. Yeah, we could have done that. But then it was inflamed on the day of surgery, so we postponed the surgery on that day, and then eventually when the patient came with the extrusion of the cyst and got the cyst alongside, so biopsy confirmed it all. We also scanned for other cysts in the brain or somewhere, but there was no other, but still we went for the empirical therapy. I didn't get you, ma'am. Yes, ma'am. It was continued for three weeks. 6 weeks we continued the albendazole, but inflammatory stage alongside, when we continue albendazole, there is inflammation with the cyst also. So if the cyst is dying due to albendazole, then inflammation is there. So to take care of that, we start steroids alongside.
In a tapering dose, right?
In a tapering dose, definitely.
Very extensively covered cysticercosis topic by you.
Thank you, sir.
Excellent. Didn't you do B scan in this case?
Sir, actually patient already had a CT scan report,
Okay.
so we didn't actually. Yes, yes, ma'am, definitely. Yes, sir. Yes, ma'am. Yes, ma'am.
So we have to, yeah. We have two learning pearls out of this, that even after you have a scan with you, CT scan, you should also think about the B scan.
B scan.
And second thing, we should have patience that you kept throughout the saga.
And one more learning pearl, revisit the CT scan again and again. Sometimes we keep
We
on
tend to
misdiagnosing.
miss, yeah.
We miss a lot. So we have to visit it.
Yeah.
We asked for the non-vegetarian diet
At
as
times, yeah, but Yeah, but at times it is not always true for all cases. Yeah, we should
But
ask.
in this case, the typical position of an angular dermoid, and the imaging was there, and there was a previous picture which was shown, and in the location, the incidence of eyelid cysticercosis is 0.6%. I have shown a previous picture which was there 3 months before. Yeah.
Cyst might have migrated.
Migrate. Thank you, ma'am.
Thank you.
Thank you.
So our next speaker is our esteemed guest from United States, Dr. Don Kikawa, Professor Don Kikawa. He is giving his keynote address on 10-minute ptosis repair. Eager to hear you.
Thank you, Vishal. This talk is, 10 minutes is a time that we set for a goal. What do we tell our fellows and residents? Time is not important, but certainly we can be good surgeons and fast surgeons, but you don't want to be a bad and fast surgeon. So whatever you do, just to do it properly and correct, and time is not that important. Some of these techniques were nicely covered by Dr. Santosh in his talk. Ptosis in any form is a challenging operation, and certainly the case that I demonstrated this morning is not a 10-minute case. So these are cases that are very carefully selected. Even master surgeons can be humbled with very simple techniques, but efficient surgery is predicated upon good anesthesia, patient cooperation if needed, hemostasis, and good surgical skills. So is 10-minute surgery for ptosis possible? It is. I think the less time that we manipulate and touch the tissues, probably this leads to a little bit faster recovery. And we want to keep our results the same. Just because you're doing a procedure in 10 minutes doesn't mean that you're expected to have less of a good result. Again, these are acquired cases. Probably congenital cases are not the best cases for this. The surgery is predicated upon the anatomy of this area, which is the conjoint tendon, where the levator, the tarsus, and the septum fuse, and that usually provides the key landmark for any of our external procedures. I'm just going to take one step back and discuss the physiology and maybe the thoughts of levator versus Mueller's muscle. So the traditional thinking is that the levator is the main lifter to the eyelid, and Mueller's muscle provides an additional 2 millimeters of lift. But based on some dissections, particularly by Hirohiko Kakizaki, I think what we're kind of now realizing is that the levator is still the main lifter, but the Mueller's muscle is the main attachment to the lid. We're always taught, well, the levator inserts on the tarsus, and that is the main attachment. But I think if you look at this broad attachment from Mueller's muscle, it's more of a dynamic, changing tension band that adjusts based on our emotions and how our sympathetic innervation innervates the eyelid. So it's very dynamic. It's constantly changing tension that we achieve. And another way to look at it is the levator is the locomotive that drives the train, and Mueller's muscle is the linkage between the locomotive and the rest of the train. And as patients age, this rubber band gets stretched out. And certainly that's something that we can address. So in answer to the first question that I asked is, which is more physiologic, levator or Mueller's surgery? Actually, if you think about it, tightening Mueller's muscle may make more sense in terms of how we actually bring the eyelid back to its normal physiologic state. This is the principle that Dr. Santosh talked about earlier. So this is Herring's law. If you see a unilateral ptosis, just make sure you manually lift the ptotic side. And if you look at the opposite side, you'll see that the other eyelid comes down. So this is a example where you may want to perform surgery for bilateral surgery case, even though you see the ptosis primarily on one side. So there's two procedures that I would consider for small, the 10-minute ptosis repair. One is a small incision levator surgery. The second is a conjunctival amelorectomy. So the small incision levator technique was described by Mark Lucarelli and Brad Lemke. This is probably 2 decades ago. There is a couple caveats with this surgery. You usually do not need to perform, or you should not perform concurrent blepharoplasty. So these are cases where you don't want to take additional skin. It's just ptosis only. They have to have good levator function, minimal sedation. This can even be done under straight local anesthetic. I typically don't sit patients up. I know this may be variable from surgeon to surgeon, but I find if they're awake, they're able to cooperate, I don't need to sit them up. Sometimes if they're sleepy or drowsy, I think sitting them up does wake them up and you get a little better view. So this is done through usually an 8 to 10 millimeter central incision. There are some contraindications if the lid is floppy, if they have floppy lid syndrome or excessive laxity. As you know, if you put 1 or 2 sutures, that's not enough to get good contour because you get a peak. So these usually have to have lids that are relatively not lax and fairly taut. Thin lid tissues are usually also not a good choice for this procedure. Anxious patients, patients with poor levator function are also not good choices. So once this central incision is made, the conjoined tendon that we talked about earlier is open, and then the septum is open, the levator is identified, and then we actually will expose the upper tarsal border, and we will place a central suture to adjust the contour and level. So this often is adequate for the entire ptosis repair as a central suture. Occasionally, if you need to, you can open up the incision slightly and put an additional suture in. So this is a video showing the small incision ptosis repair. So this is about an 8 to 10, 12 millimeter central incision. Skin incision is made. We use the monopolar cautery, which is good for hemostasis as well as dissection. This is exposure of the upper tarsal border, and then that's the grasping of the conjoined tendon where the levator and septum fuse. We open up that central pocket, and then you can see the edge of the levator aponeurosis. Once this is identified, we can actually place a central suture to advance that. This is a 6-0 proline suture. It's done in a horizontal mattress fashion, so this is the tarsal bite. And that's about the rough position of where we place the suture in the tarsus, the central third. We check underneath just to make sure it's not full thickness. And then we advance the other aspect of the suture, bring it through the levator, and we tie a temporary knot. And then we ask the patient to open their eye, and you can see that's a pretty good adjustment. So we are often asked, where do you set the lid in an awake patient? Do you set it where you want it? Do you set it a little higher? Or do you set it a little lower? Personally, for me, I go a little higher because when the orbicularis kicks in, it usually comes down about 1 millimeter or so, because we are paralyzing the orbicularis when we put the anesthetic in. So either at the level or slightly higher is what I shoot for. So if we get a good satisfactory level, we tie that knot off permanently, then we put skin sutures in. This just shows the intraoperative adjustment, and then if the sedation level is high, we give them a moment for the sedation to wear off. These are some examples of the pre and post small incision levator procedure. So you can see without the need for skin excision, we make a little incision in the crease, and with a central suture, you're able to get very nice elevation and contour. As you all know, some patients will complain if you don't take any skin out. They will get some advancement of the dermatoclasis as you lift the lid. The skin comes down, so just be cognizant if you don't warn patients of that. For example, in this patient here, patient was happy with the lid level but complained about extra skin. So this is something we all have to take into consideration, that when you elevate the lid, the dermatoclasis comes down, They're not using their brows as much. You see the brows come down. So you have to warn them, we may need to take skin later. If it's something you think about in advance, then probably you can incorporate that into your incision, but you're going to have to extend it. That's not a small incision levator procedure or skin excision. Some of the complications Dr. Santosh talked about: over-under correction, contour abnormalities, wound dehiscence I think is pretty rare. Hemorrhage is also rare. Okay, let's talk now about the conjunctival amelorectomy. And you might ask, well, when do you use one or the other? I think for smaller amounts of ptosis, 2 millimeters, you can use the amelorectomy, if provided they respond to phenylephrine. If it's more than that, then the levator is your better procedure. And again, there's no reliance on intraoperative lid levels with this procedure. No need to wake the patient up or do any sort of adjustments. All your decisions are made before you do the surgery. Phenylephrine testing, I use it for unilateral cases because it usually gives you the patient idea what it will look like postoperatively. If it's a bilateral symmetric case, I don't test it all the time because I know I'm going to get a pretty predictable lift, and as long as both lids are ptotic at the same level, I'm going to do the same amount of surgery. So this is the phenylephrine effect here, which is useful for, again, unilateral cases. So the anesthetic for the conjumulars, it's either a frontal block or local infiltration. You evert the lid, and if I'm going to do an 8 millimeter resection, I'll mark 4 millimeters of where I place the central traction sutures. So this is the lid everted. We can visualize the upper tarsal border. And these are skin marking pen with a caliper. I mark half the amount of resection, and then I place a silk suture into the central marks, and then you can see the levator, excuse me, the conjumulars gets folded over, so that's how we get half the amount, because we get both sides on either side of the traction suture. A clamp is then placed, and then we will weave a suture. So this is a brief video showing the conjunctival amelorectomy. Shows eversion of the upper eyelid. You can see the superior tarsal border. And then this is the, I'm just going to briefly pause here. This is the amount of resection that we usually plan for a conjunctival molars. Most of the patients fall into this 2 millimeters of ptosis, which is 8 millimeters of resection. So we mark half the amount, which is 4 millimeters in 3 different locations. We'll weave a 6/0 silk suture, just a little slip of conjunctiva. Then that gets elevated. And then the clamp gets placed just to the level of where the superior tarsal border is. The silk gets removed, and then this 6/0 proline is weaved underneath the clamp, back and forth, and we'll externalize that onto the skin surface so there are no exposed sutures on the conjunctival side. We perform our conjunctival molars resection, and then we tie that proline off externally. This gets pulled at about 1 week. These are before and after conjumulars in the left eye. This is one on the right eye. You can titrate it. If you only need 1 millimeter of lift, you can do a 4 millimeter resection. So the advantages of amelorectomy: there's relatively predictable elevation. It's very useful in congenital cases. It can be done under general anesthesia because there's no need for intraoperative adjustment. Just be careful how much conjunctiva you resect. If there's any conjunctival pathologies such as symblepharon, giant papillary conjunctivitis, any sort of follicles, just be careful. I would probably avoid that and do an external approach just because you're worried about scarring. I find sometimes congenital cases are a little bit unpredictable with molars, so I prefer to do the anterior approach. So in summary, predictable ptosis repair can be obtained in 10 minutes or less. Results should not come at the expense of time, but efficiency is helpful to both the patient and the surgeon. And again, thank you to the AIOS for inviting me to speak. Thank you very much.
Thank you, sir. I have a question for you.
Yes.
Which patients are suitable for this molarectomy procedure?
I would say the question is what patients are suitable. So I think 2 millimeters of ptosis Unilateral, if it's a bilateral case, I think bilateral symmetric ptosis without any conjunctival pathology.
About the LPS function, how much it should be?
Yeah, the question is about how much levator function. I think they should have at least good to fair function. If it's low levator function, I wouldn't do it. I would do an anterior approach.
Thank you.
If the phenylephrine test is negative, I usually don't. If it's unilateral and the lid does not come up with phenylephrine, I'll go external.
If the test is not positive, then you won't go ahead with the mullarectomy process.
Correct.
Right?
Or if it comes up a little bit, then I'll do a fudge factor and I'll do more than what I would normally do.
But then you also said that in bilateral cases you don't do the test.
Not necessary in every case. Bilateral symmetric. I mean, if you have time, you can test it. But I think most of the time, if you get symmetric lift bilateral, the patient's not going to usually complain too much.
Okay.
So if you want to revise a case which has been done by mullarectomy approach earlier, now you are planning to do an LPS for a residual doses. So will you go by the same nomogram, or you could under-correct your plan, or you over-correct your plan?
I think if it's a re-op from an external that you're repeating internal, I would keep it the same. Yeah. Some people even talked about repeat Muellers. I don't like it because it takes too much of the fornix. So.
Said in a small incision, ptosis
Levator.
correction, levator, you did, if there is any contour abnormality, how will you take care of that thing?
So I try and correct it on the table. If there's a peak, or if it's too nasal or temporal, I can place a second suture. You can kind of slide the incision over a little bit, or you can extend it and put a second suture. So I try and deal with it at the time. I think the goal of keeping the incision small is kind of more of I guess it's kind of a goal we shoot for, but it doesn't necessarily have to always be 8 to 10. It can be a little bit larger. It just heals faster, and sometimes the incision is not even visible in these patients. Thank you.
Any questions by the audiences? Thank you.
Thank you.
So can we have all the speakers together to have a group photo?